So if we do a facial assessment, everybody sees beauty is a kind of perception which you have. What I like and consider as beautiful, I would like to transfer this to the patient. This might be okay, but this might be also wrong. So the problem is to match my ideal or perception of beauty with hers. Okay? And when I see and when I looked on her, maybe you can come a little bit closer. And that's why I picked her today, is because I have a different technique which I want to demonstrate you, because I'm injecting temples on her very superficially. I do it completely different than the most of you do. Who injects temple tips with the shotgun technique? Can you raise your hands? Who is using a deep injection? Oh, okay. Who is going superficially? Oh, great. So they have also some superficial injections. So understanding the rheology better means superficial injection has some advantages. You need less product. Projection is very nice. If you go deep on the bone, there's a transition here, so you might lose product by having it to the buccal space where we do not need it. Yeah. There's one case in Germany, they have been injecting on the bone, and actually they have been into the brain. So there's a case of HA injection into the brain when you do this with candle. No. Yeah, no. That's why I'm not a friend of. That's why I'm not a friend of deep injections. I always go superficial for these reasons. The side effect rate is much less. I want you to demonstrate by purpose now how I'm going to inject Blotro volume on her superficial with a cannula, and how easily this product is moldable and formable. And that's why the temples are so nice. Of course, she's a toxin patient. We are not allowed to speak about the toxin, but she would be ideal for the crow's feet and for the glabella line. She's absolutely naive at all. And also, because you've been stressing this, you know, if you look at her from the side, can you turn like this? Can we see her? Yeah, no, this was better like this. Yeah, you see that her chin is very much projected, and you see if you release it a little bit, if you just relax it a little bit with the toxin, her mental crease would be much better. She's constantly contracting with her chin. I am not a friend of the filler injecting first. We can discuss this controversially, because this looks blown up, this broadens her chin, and she looks masculine. This is something I do not want. So my task for her was today. We can also do the temples. So what is my anatomy we have to think about? This is the temporal fusion line, so crista temporalis.
Guys,
so
can you see, or do you want the lights down a bit? Can we turn the lights down in the room a little bit so everyone can see, because there's a bit of a reflex. Yeah,
perfect, thank you. So this is my border superiorly to the forehead. And then we have the anterior border, which is the orbital rim, roughly here. And then we have the zygomatic arch with the inferior border. There is no border backwards. What is the structure we have to take consideration of, or which we are aware of? This is the superficial temporal artery. We have two arteries, the superficial and the deep ones. But more it's the superficial artery. You can palpate it sometimes if the patient has a high blood pressure, but in her case she's very relaxed, so I think she trusts me. What is the structures? We have the skin, we have the subcutaneous tissues, which is very low, and then we start to have the superficial temporal fascia where the vessels are embedded. And then we have the muscle, and then we have the bone. The muscle is attached on the bone. So you can never do, if you're injecting deep, an injection on the bone. It's an actual intramuscular injection you're doing. You have to be aware of this. Okay? And the problem is, I'm just stimulating it. If you go with the needle on the bone like here, the patient turns her head like this. So you have to follow her to stay on the bone, which is not so nice. Because if you move your needle backwards, you might be exactly in this area where you have these arteries coming. Yeah. The other thing is, which Sebastian Cotofana, and we both like him very much, has published recently, whenever you have a needle and stick with the needle into the tissue, you create a canal. And knowing now something about rheology, the product goes the easiest way. It flows back. This has been demonstrated on the forehead. It's going to be published on the temples as well as on the teardrop. So that means your product, even if you touch the bone, even if you're in the muscle, never stays in this tissue. It flows back much more superficially. And there are many, many cadaver proofs on this. So that's another reason why I prefer a superficial injection with the cannula. Do you agree or not? Okay.
I like it. I like it.
So we are on the same track in this way. We are different on the lips. I do my lips differently, but we can discuss this if you want. Okay? So stay superficial. You don't need much product. You have no loss of risk of dropping it down. You are far away from the arteries. The only thing I have to tell you now, and I'm not, of course, you know, I'm not employed by MERTS. The thing is, you see some skin, you see some irregularities with superficial injections. This you have to tell the patient, and this you have to know. And you cannot do this technique so easily with any other competitive products. If you use Bellotero volume, you can mold it and massage it easily. So you can be a bad injector, just put some boluses on the skin, under the skin, and massage it, and the product is distributed evenly. I will demonstrate this to you now. And you can also touch and feel in the first row if you want. Yeah? You feel the product, you massage it, and then it's not gone, it's softened, it's then spread out a little bit. Cohesivity, coming back to this, cohesivity of Bellotero volume is lower than cohesivity of Bellotero balance or Bellotero intense. So that's why this has different rheological properties. It's lifting, but it's also moldable, and you can easily massage it and spreads. That's something you have to understand, which is not so easy. You do it clinically and you get a nice results, but I want you also to understand the science behind it a little better, even if it's a dry topic. Next time we switch, I do your talk, you do mine. Okay, so, and then, you know, we can do the marionette, sorry, just look on the camera. So we can also do the marionette lines if you want, because we don't want her to turn to our Chancellor, Angela Merkel, as long as she's in charge. I do it very easily. I'm actually a cannula guy, to be honest, but in this reason, I can show you a very nice trick, which is quick and safe and easy with the needle. Yeah? And we can also do some mid-phase, but I think I do the other patient for the mid-phase. It's better. Which is nice. Okay. I remove the paintings. You know, I'm always very generous when I'm... whatever. Can I take mine with the 20? So I'm using... No, the other one. This one. So my cannula I've been using, I brought them from Germany, is TSK 22G. It's very short and it's very stiff. Why do I use it? Because I do not want the cannula to bend away. Because it's a matter of precision. I want to see where I am with my cannula to give a precise injection. And that's why I prefer a short but quite stiff cannula. Okay? And can you put this? And now this is the Bellotero volume I'm going to inject. Once more, I mark the borders. I start priming because I always do a little bit of tissue, a little bit of product in the cannula. So I prime the cannula, I give it to you. I remove my glasses because I can't see with glasses. I think this one is too... Can I get... No, I need the green ones, the other ones, to make the insertion point. Yes, this one. Thank you. So the only thing you might feel is a little prick. So once more, you can see the hollowness of the temple. I'm not sure if you can see this clearly. Yeah, it's clearly visible. You see and this gives a kind of wasted appearance. You know, we do not, especially women, do not want to look wasted. Okay? Do you say wasted in English?
Yeah, it kind of means like a little bit.
Okay, now how do you say it if there's a hollow? It's
very hollow. Yeah.
Very hollow. Okay. Yeah. So what I'm doing now, no, relax.
No, there's alcohol in
okay.
my eye.
Can I get a dry? Oh, sorry. Okay. Sorry. No, it's fine.
It's in my eye.
Is it better now? Do you need a tissue for you? Okay. So the only thing you might feel now is a little prick.
Should we zoom out a little bit so we can see the full face and keep the patient's breathe still?
So I palpate my upper zygomatic arch. I'm using now a needle for the insertion point. I stretch the skin a little bit. And my insertion needle, my insertion entry point defines me the level of injection. So if I want to go deep, I go perpendicular down, which I do not want. And I'm doing it superficially, sorry. And then I do not twist, I do not do anything with the needle. It's like acupuncture, then you get 20 needles and the patients do not complain. So I just leave it. If I would be in any big vessel, blood would come out now. So, okay? And now I remove and see, almost I can find a hole. So now my bevel is up, stretching the skin. And what I'm doing here, this is my plane of injection. It's subdermal injection, clearly to see. And what I would like to do is, I'm stretching it and I'm doing a kind of subcision. Sorry, this is discomfort. Sorry, is it okay?
I'm fine.
You're fine. You let me know if I'm too rude.
Torsten, can I ask you a question?
Yes, sure.
For those of us who haven't done it, for example, how do you know your subdermal? Is there any way
You do not know, you have to see the visibility of the cannula.
Yes,
So that's the
yeah.
only one which you never know if you're subdermal. I have done so many courses with Sebastian on temples, and we have done the dissection afterwards, so you are. But it's never 100%.
Yeah.
You can never, if somebody tells you he's 100% sure he's in the subdermal tissue, he's lying. Okay? And now I'm giving a little bit of product and augmenting it.
So 22 gauge cannula, and you're using volume at the moment?
Yes, I'm using volume, little threads, and I'm doing a little bit irregular for you. Just, you see the irregularities? Do you see it? Well,
is the lighting good, or you want it darker?
can I get a gauze? Yes.
Can we make it darker?
But if you can, and now I'm massaging it. 1, 2, 3, gun. So you can be a very, not bad, but maybe sometimes you're not concentrated. Sometimes you do mistakes. We are all human beings. With the Bellotero volume, you're always on the safe side because you can massage it gently and press it into the form you want it. Okay? Are you good?
Cool.
Good. And you can also do a little bit of lifting on the eyebrow, injecting more.
So this is, again, really subcutaneous here, right under the skin.
You see the material.
Yeah.
If I would be too deep, if I would be under the fascia, you do not see the material at all. Would you agree?
Nice. Very nice.
And then I massage it. So that's the problem, and that's why I say this is a technique you can do easily with Bellotero volume. If you use, for example, Restylane, just to mention one product, this is more particulated, so the molding out and the massaging out in the subcutaneous tissue might not be as easy. Yeah? And why do I do subcision? Why do I undermine the tissue? Because I want to create a homogeneous layer and place the product as even as possible. Sorry?
Does it matter what the bevel of the cannula is? I mean, are you
Yes,
specific? Yeah.
it matters, and I try to be with bevel up.
Bevel up, okay. So far you've almost used a 1 mil, right?
Yes, she was very hollowed.
Hollow, yeah.
So 1 mil is what I have calculated. When I saw her on the picture, I thought I need 2 mils, but I think 1 mil is fine.
Yeah.
It's a huge area, and we have to augment it,
Can I ask something?
Sure, everything.
What do you think?
I'm not sure if I can answer.
What do you think about the technique that you go 90 degrees?
Like a gunshot,
Yes.
yeah?
I hate it. I told you. First, the patient turns the head away. Second is you might lose product by descending it into Bichat's fat pad. Third, there's a case of HA in the brain in Germany. So the power you need is only 4 kilograms, which is only very few. And I know the physician who has injected this patient with HA in the brain. It's a woman like you, but like this. Very small, no power at all, no strong forces. So you do not need much force to bring the HA into the brain. Sometimes, if not, it goes down.
But sometimes you can use the cannula between the two fascias.
You can use, but this is more tricky. Whenever I go in with the needle, I determine my insertion, and then I have no resistance. Whenever I go over the resistance, I penetrate the cannula. So this needs much more power. And have you seen me injecting? I was very gentle. If I feel the resistance with my cannula, I'm above the fascia, and I don't push it further. I'm just stay superficial, so no pressure at all. Okay, you can use your 2 fingers just to do so.
How does the patient feel? How does it feel?
Yeah. How does it
A
feel?
bit of tension in there? No. Relaxed. She looks very happy.
It's good.
Good.
Try to be. The thing is, if I went back like here, this was more problematic, or was it more discomfort?
Yeah.
So this is a very, very fibrotic area in the hairline here. So when you're injecting here, you need a little bit power. And you cannot do this with a 27G cannula, because 27G cannula is as sharp as a 27G needle. So you have no advantages. This has been proven also in a new study. And the other thing is, this bends and turns away, and you're not precise at all. So that's why I really prefer a stiff cannula.
All right.
Okay? So what I can do now quickly, if you want, I can show you and demonstrate. Can I get some Bellotero Intense with the 27G needle? I will show you quickly how I can do my marionette lines. So what do I think is a good technique? A technique is something you can start tomorrow with, which you get a constant results, which are very, very nice. If the technique is very fancy, it doesn't help you a lot. Okay? So I like it easy. I'm a guy. I'm easy. I cannot think properly. I don't want to think too much in my life. I want to make my life easy and convenient. So that's why I like easy and convenient injection techniques. You cannot inject Blotero intense with a 27G, with a 30G needle, sorry. You have to have a 27G needle because this is otherwise too stiff and too hard. More cohesive than volume, 27G needle here. Volume you can inject easier with, you can inject it quite easy with a 30G needle. Okay, what I do, I pinch the skin. Can you see? I pinch the skin, and I'm like Uliana, I'm subdermally, so I'm a very superficial injector of Blotero, because tissue integration is so excellent. And what I do in here, I just prick in here and do a tiny bolus of 0.1. One. She has no amla on it, but there's lido in. And then you see, I'm not sure if you see this here, it's already lifted. With less than 0.2, tiny bolus, you have a lifting and projection effect, and also a volumizing effect. And the nice thing with Blotero Intense is, I can also use it one more. I can also use this to elevate the corner of the mouth. Yeah? Is it okay for you?
Yeah.
Okay, so what I'm doing here, is it on the screen visible?
Yeah. Good.
So I open the corner of the mouth and go into the lip and make like a horse show. 3 injection points with minimal aliquots of product. Sorry, one is here. She doesn't like it. It's in the lip. She has nothing on it. Sorry, second one, almost done, and the third one. And this should elevate the corner of the mouth. And then I'm doing one more line here, just to support it. Oops, can you turn like this for them? Thank you. And one more line here. And then we are done. This side was much deeper than the other side, but now it's pretty much the same. I can do the other one as well quickly, if you want.
Yeah, please.
Yeah, but we decided to finish the patient anyhow afterwards. See, here's much less of depression. If I press it down, the other side was much more. I stretch it. Sorry, one more prick. Is it okay?
Yeah.
Can you press here just to avoid bruising? Can you press here? No, not with that. Like, okay, thank you.
Sorry.
No problem. Sorry, I know. It's with lidocaine, but I have to change the side. Can I go? Thank you. And one more, the Mona Lisa smile, you can call it. Open the corner of the mouth. Do a little of injection here. One injection here, and one injection into the upper lip. Sorry. Now you're done. Can I get a dry gauze? Yes, thank you. Just to elevate it a little bit. It was less than 1 cc, 0.8 for the entire marionette lines. Okay? Can you see?
Yeah, it makes a huge difference.
Yeah.
Huge difference.
Yeah. Of course, it's not a miracle. It's not a lifting like this. I cannot push it up 1 centimeter because gravity and anatomy, you know, we have a ligament here, so this is always something which prevents it from but if you do a facelift now, like this, I'm simulating this like here, you see not much lifting effect here anymore. So even with a facelift, you would not have much benefit on the corner of the mouth. Okay, and this was less than 1 cc, yeah, which is almost, you know, almost nothing. What I could do with the rest, I'm not sure.
Can I ask you a quick question? Is there anything
sure.
you can do for that chin crease? It really bothers me. Is there anything you can do with fillers for the chin crease?
Toxin.
That really is the toxin for you?
Yeah, I think, you know, because she's so strong, you have to palpate it here. She's,
I was born like this.
yeah. Yeah, but this is really toxin, 6 units in here. She would relax. If I fill her in here, what happens to my persuasion? Optically, I will shorten this distance too much. And she will have too much anterior projection, which masculinizes her anyway, and she has too much anterior projection, so I want to reduce it a little bit. That's why I would go for the relaxation of the skin first. She's a typical Xeomin patient, or whatever you might use for the toxin, okay? Do you want to do the other side as well quickly on the temples?
No, I think I've got the patient ready for lips in a minute, so you can finish off if you want to, or you can, how are we doing for time? Can Torsten finish the other side, do you think?
Or I can show you how. Okay, fine. Then I need one more Bellotero and my cannula. Volume. The same. Are you doing good? Good. This was a little bit pain. Sorry?
Where's my other ball?
Where's your other ball? I don't know. Where's the ball? Ah, here. You get it. But this you already know.
Yeah.
This was a little bit painful because it was in the lip and she has nothing on it. Sorry, turn the head like this. Once more, anatomy. The border here is temporal fusion line, crista temporalis, orbital rim here, zygomatic arch. I disinfect once more. You have some irregularities in the skin, which is not a problem at all. When the patient sleeps, tomorrow when she wakes up, everything will be gone. So here, little prick, superficial, almost parallel. Thank you. When you use the Bellotero, this is glass, this is plastic. You touch it, you hold the Bellotero on the lure lock, and then you put the needle into, or the cannula into the lure lock system. See, no bleed is here still. Can I get a dry one? Dry gauze? And I do quickly the other side. You see I'm in here with my cannula. You see how it's not flexible at all. It's very stiff. Bevel is up. Stretching. Subcision. Gentle. She's very nice. If the patient has pain, I place some product in here because it's with lidocaine. And you see, I demonstrate this once more. You see this line here? That's why I'm superficial. I'm above the fascia. And now I massage it. 1, 2, 3. It's gone.
Torsten, if you had a really thin-skinned patient, will that change your approach or your filler choice at all?
Oh, you have to see the patient in general, but I would not think so, because, you know, I would be maybe more cautious with the volume. But, you know, if the patient is really very thin, I would ask Marina and me to do a phenol peel on her. Maybe that helps a little bit anyhow. You know, these very thin skin patients, they're not ideal for filling at all. But you can try, but I wouldn't change my product too much. If she's very hollowed, I go for the volume. Yeah? And I have never seen any risks or side effects, you know. The only thing is you see the irregularities a little bit more, and in the thin skin patient, the veins come up, like they do here anyhow as well a little bit. So what you see here is the veins coming up, which is absolutely normal. And yeah, we have to deal with it. But this goes away in the next, okay? So you see, can you see this in the video? You see the irregularities? I have to put back, yeah, it's not so much. Can you see these irregularities here? Okay. And I massage it away. Very easy.
And then for a week after the treatment, is there any advice you want to give to the patient, or just carry on, have fun?
You know what I did with my temples? I got injected in Dallas, and I just went into the airplane and flew with it. Nothing happens. What is the risk? It stays in place. I can massage it. It doesn't dissipate. It's a good cohesivity compared to other products. What should I take care of? To be honest, not much. We have a glass of wine together. Yeah? Okay?
Torsten, we had one delegate here asking, is there any chance you can talk about your lip?
Yes,
with
sure.
Because you said you use volume for lips. This is interesting.
Yes, volume is my preferred lip filler. Why? And actually, you shouldn't have 2 lip products. If you had 3, it would be even better. It's adaptive to mimic activity. When I kiss, when I smile. And I need a product which is elastic and which is plastic and which is moldable, because lips are so movable. And my idea of injecting lips is something different. Can you sit up maybe, just for them to show? What is the problem with lips? You have shown this so nicely, all these frog lips and dub lips and the celebrities, you know, who have these ugly lips, which we are all afraid of. So what happens by the aging process? By the aging process, as you mentioned already, the lip inverts. It's an elongation of the upper lip. So what I want to do is an eversion. I want to push the lip outwards. So what I'm doing is, I take the dry wet border and do threads 1, 2, perpendicular line. So can you open your mouth? I see the dry wet border, which is here, and do linear threads 1, 2. So it has two effects. This creates volume here a little bit, and this is like a hypomorphium. So if these are my teeth, and this is my lip, this is my HA, the HA presses the lip outwards, and it everts the lip. If you like to have volume, this might not be sufficient. Sometimes they say, okay, can I get a little bit more? And then I'm doing this way like you're doing it. Then I put it subdermally with the needle. I prefer the needle because I'm more precise. So then I'm going in here. Sorry, okay, close the mouth.
Can we, Torsten, if you look at the camera, if the patient looks at the camera, so we can
okay,
see,
okay, thank you. So then I'm going in here and I'm doing a little line here just to volumize the lip subcutaneously. But the more I'm injecting subcutaneously, the more projection I get outward, which I do not want because I want an eversion more. And that's a kind of resistance that everts me my lip like this, and this gives a quite natural result. That's something different. It's a combination of everything, so it's not an either-or option. And defining is my dry wet border, which is always very easy. Can you, like this, open your mouth? Yeah, you see the dry wet border here. It's clearly visible. And this defines me my entry point. So with my non-dominant hand, I palpate like this, and then I go in with the needle perpendicular.
So sorry, the wet dry border, you mean right in the middle of
the...
Okay.
Yeah. And remember anatomy, here I'm under the muscle because I'm very deep. Here I do not do, because here I might have risking of hitting the artery. But here in the central part of the mouth, you're absolutely on the safe side. Anyway, aesthetically, if I go laterally here, I broaden the mouth too much, which is not so happy in many patients. So you have to define this with the patient. And what I'm doing, patient gets a mirror, I'm injecting one line, patient sees the difference. If not happy, do a second line. If not happy, starting to volumize. And yeah, if you have the time, I can do, sure, no problem. So it's a little bit different, it's a combination of something. But the idea is teeth, something stable, which puts the lip outwards. It everts the lip. How do you feel?
I'm cool.
Good. We do anyhow finish you later. Is it, how is it?
It's strange.
Strange? Because it's numb. There's lidocaine on it. Yeah? Okay?